A 50-year-old hypertensive woman, first let us see the image based questions, complains of numbness and weakness in her left leg and foot. What is it called? Contralateral lower limb monoparesis. See, there are three cerebral arteries, as all of you know very well. Give me the book. You have ACA, you have MCA, you have PCA. The two vertebral arteries combine to form basilar artery. Basilar artery divides into posterior cerebral artery. Then meanwhile carotid will be giving rise to middle cerebral artery, and there is also anterior cerebral artery arising from the carotid, circle of Willis. If you take PCA and basilar artery, they mainly supply the brainstem and the connections of the brainstem with the cerebellum. That is the reason whenever posterior cerebral artery stroke is there, what are the predominant symptomatology, doctor? Vertigo, vomiting, etc. Patient will be crying, shouting loudly whenever they have a PCA stroke because they have a tinnitus, vertigo, very dramatic clinical appearance. Then middle cerebral artery mainly supplies the motor cortex. That's the reason opposite half of the body you get hemiplegia, contralateral hemiplegia. Then what does ACA supply? Typically if you take the entire cerebral cortex, you remember that homunculus, the motor map of our body. You have got two cerebral hemispheres, motor map. Then in the motor map, this strip is there, no doctor? This is the area where our leg is represented. And the tongue, face, body, everything is represented in the different part of the cerebral hemisphere. So the strip where our opposite leg is represented is that strip which is supplied by anterior cerebral artery. So in anterior cerebral artery you don't get hemiplegias. What do you get? If my right anterior cerebral artery is occluded, I will get a left lower limb monoparesis is what you need to basically remember. So whenever patient has got a contralateral lower limb monoparesis, and what does any infarction in the brain will lead to? Spasticity, right? Because cortico-spinal tract, pyramidal tract get affected. So you will get spasticity in the contralateral limb. What is the meaning of spasticity? Increased tone of the joints. When the tone of the joint is increased, can you freely walk? You cannot. So the patient will be dragging his contralateral lower limb. Any elderly person who had a ACA stroke dragging his lower limb, everybody will think what? Maybe this man fell somewhere and he had a hip fracture. So a lot of times patients are admitted under orthopedic care. Orthopedician will be ordering all x-rays. Nothing will be found. He will be thinking why he is dragging the leg. Then as a wonderful house surgeon, you have come to see that patient. Because he said, I could not see any fracture to fix, please discharge this patient. He is not our broken bone kind of a patient. Then you have done Babinski. Then you found that limb which he is dragging Babinski positive. Then you thought why Babinski should be positive in this limb. Then you will suspect a neurological lesion and then you will get a MRI done. Typically this is the area, the strip which is being supplied by anterior cerebral artery. And any occlusion of anterior cerebral artery, this is the area of the cerebral cortex motor map which represents our lower limb, contralateral lower limb. So you will get typically contralateral lower limb monoparesis is what you need to basically remember. Okay, doctor? Then once more, stroke is one topic. Definitely out of 6 to 7 questions in neurology, out of 30 questions in general medicine, one will come from stroke. If you miss it in medicine, you will get it in anatomy. So that's the reason circle of Willis, branches of internal carotid, so everything you must be giving a finishing touch. 15-year-old boy has been hit and he became unconscious, and later on after 10 minutes he regained. What is that called as? Lucid interval. Lucid interval is a typical story of epidural hematoma. So this is a typical biconvex shaped epidural hematoma. And what is the source of that? It is a bleeding, arterial bleeding that comes from the rupture of the middle meningeal artery, which will be running underneath the calvarium and above the dura, is what you have to basically remember. Very good. I am very happy to see Divya and many more who are online. Now doctor, action potential curve. You have an upstroke, you have a downslope, you have an after polarization. Everything, anything about action potential, very high yield topic. Okay. So those who didn't collect the topic list, did you collect yesterday? Huh? You have given, no? To the everybody have the topic list. Don't read everything in the book. Physiology means totally 60 topics. All 60 are also not required. First 30 topics, if you read, you can answer those 5 questions in state entrance comfortably. If you are going for all India, at least 60 may 45 topics if you read also. Out of the 15 questions in physiology, 12 to 13 comfortably you can answer. How much time it will take to read 45 topics? 4 topics an hour, 10 hours you can finish up and throw it away. Provided you know what to read. So upstroke is because of what? It is the net inward current, and the cell interior becomes less negative because of the inward positive current. So the sodium ion movement is responsible for that. Upstroke is what I want to underscore to all of you. So you have a upstroke, overshoot, downstroke and undershoot after hyperpolarization. Now if you do repeated stimulation, what does it lead to? Tetanus. So what is the tetanus? Because of accumulation of calcium. With every stimulus, sarcoplasmic reticulum releases calcium. If you give some time before one stimulus and other stimulus, that released calcium has a chance to get once more taken back by sarcoplasmic reticulum. But if you are repeatedly stimulating, calcium remains, and that leads to development of a tetanic contraction, is what you have to ultimately remember. Then doctor, you have been shown in ECG. You can expect at least 2 or 3 questions on ECG. At least one definitely to hoga, at least 2 will be there. So we had a marathon session of 4 hours on ECG, and everything about ECG. You can review that. Right sided leads, left sided leads, how to decide axis, rate, rhythm, everything, ST segment, T wave abnormalities, everything. Okay. So what do you find here? Premature ventricular complexes. What are they? They are nothing but aberrant forms of QRS complex. This is normal QRS, this is normal QRS, this is normal QRS. Suddenly in the middle what is coming? Aberrant QRS complex is coming. What is, इसको क्या बोलते हैं? Premature ventricular complex, PVC it is called as. So what is the effect of PVC? PVC will lead to a decrease in the pulse pressure, because whenever the premature ventricular complex occur, ventricle cannot pump effectively. Unlike the regular ventricular depolarization and pumping, where it can pump efficiently, when premature ventricular complex comes, it can't pump efficiently. That is the reason the amount of stroke volume decreases, and that will also decrease the pulse pressure, is what you have to basically remember. So if you are sitting in the OP, Welcome to Anusha and the friends online. So, lot of patients come with this kind of Pvcs. What do you need to do with those Pvcs? Do you want to immediately give any antiarrhythmic to those patients is the question. Generally when the patient is not symptomatic, in a asymptomatic patient on ECG if you see Pvcs, there is nothing that you need to intervene really. Okay, so that is very important. But patients will be scared. Why? On every ECG it will be written, this ECG is abnormal, like a Supreme Court report, machine will vomit one report. There are patients really who become very sick, not because of real illness. Biochemistry laboratory report will give normal values on the side. If alkaline phosphatase is 20, they interpret 22 alkaline phosphatase as abnormality, liver failed. They go to Google and Google will tell, last before a year you have had that beer with water mixed in that beer and you have drunk, no, your liver is gone. My cousin also died like that, somebody will write a review. Internet is meant for writing reviews, no. You go to internet, you will find lot of reviews on us. Attending the classes are a waste of time, somebody will write, I lost all my money by attending those classes. And somebody will write, oh, I never thought next 50 years I will get a seat, but within first attempt only I got the seat, somebody will write. You don't know whether to accept or not. So internet reviews are very dangerous. Of course, the times have changed a lot. Even if you want to marry a boy also, there is an internet review about him, from his old girlfriends. This guy is okay on bed, but I think he is little confusing and messy sometimes. So you can decide based on the earlier reviews. Everything is nowadays review based. Now doctor, drug A binding with antithrombin and it is inactivating the thrombin. So what is this drug A? Drug A is heparin. Heparin is called indirect thrombin inhibitor because directly it won't go and inhibit thrombin, it will make antithrombin 3 to become active. Now what drugs directly go and inhibit thrombin? Argobactrin, etc. There is a list of drugs which are called direct thrombin inhibitors. So what is the structure of heparin? Heparin fundamentally is a glycosaminoglycan. It's a polysaccharide. In nature is what you have to basically remember. It will have long repeating chains of disaccharide units attached to a core protein. Hence it is called as glycosaminoglycan is what I want to underscore to all of you. Now, what are the physical features basically? What do they suggest? It is a classical case of Marfan. So what is the underlying problem in Marfan syndrome? There is a problem in the fibrillin protein. So what is the problem in fibrillin protein? The primary structure of that fibrillin protein got altered. And there is a defective alpha helix. Alpha helix represents the sequence of amino acids which constitute the primary structure of the collagen is what you have to basically appreciate. Now you have been shown drug A, drug B and drug C. Their dose versus their response. So what is the difference between them? If you look at the drug A and drug B, they both have same efficacy. What is the meaning of efficacy? This guy drug A did not take any coaching, but he got first rank. This guy drug B took all possible coaching and got first rank. But ultimately both of them have reached first rank. So ultimate response shown is same. When the ultimate response is same, then you call efficacy of the two drugs is same. Suppose if this drug A did not take coaching, got first rank, but the drug B took coaching but got 100th rank. there is a huge difference between first and 100. That means efficacy in spite of taking coaching for the drug B is lesser. So efficacy is decided by what? The ultimate response, maximum response, how much response has been shown by the drug is a deciding factor of efficacy. Then what is meant by potency? Typically if you take this drug C, it required a long dose, more dose to achieve this level of response. But this drug B, even at lesser dose only it achieved that response. And drug A, even lesser dose only it achieved that response. That means who is most potent? A. So how much dose is required to achieve a given response is called as potency, is what you have to basically remember. Now you are having a cardiovascular drug which is showing its effect on systolic and diastolic BP. Autonomic nervous system pharmacology, doctor, favorite topic for examiner. We hate to read it because we never read it in pharmacology. But please do start your preparation with a review. We have a review video on ANS pharmacology in pharmacology video library. So systolic BP of control is 120, but the drug X is causing a decrease of it, whereas diastolic BP, it is causing more profound decrease. Then possibly how is the drug X is basically acting? It is acting on beta 1 and beta 2 receptors. I will do the literature for you as to alpha 1, beta 2, alpha 2. What is the effect on vasodilatation, heart rate, stroke volume output, cardiac output, and the systolic and diastolic BP. The differences between alpha 1, alpha 2, beta 2 stimulation and inhibition. Okay. So then prazosin. Prazosin is what? Alpha blocker. I think minimum gyan already you are having about the receptors, but anyway, for the benefit of the others, beta 1 is heart. It increases the heart rate. Beta 1. Beta 1 is located on the heart. Where is beta 2 located, doctor? Smooth muscles, like bronchial smooth muscle. So smooth muscle, that is the reason beta 2 stimulation lead to bronchodilation and smooth muscle relaxation, and that is the reason all beta 2 agonists, salbutamol, salmeterol, penbuterol, albuterol, etc., we all use them as smooth muscle relaxants and bronchodilators. Okay. Then you are having alpha 1 and alpha 2. Alpha 1, where is it located? It is located on the vessels. Any stimulation of alpha 1 will lead to vasoconstriction. It is on the vascular smooth muscle, alpha 1. Then where is alpha 2 located? Typically in the brain. Whenever we are angry or whenever our professor is angry, why his BP will shoot, doctor? Simple. In the brain, there is a sympathetic outflow. From where will sympathetic system start? In our hypothalamus it will start. Hypothalamus is related to amygdala. Amygdala is related to our emotions. Emotions is related to love. Love is related to lust. Whatever the relationship. But ultimately from where all that anger begin? Hypothalamus. Right? So in the hypothalamus, the sympathetic center, there are presynaptic receptors called alpha 2, presynaptic, once more bad English. So it is pre means you expect 1, it is not alpha 1, it is alpha 2. And postsynaptic receptors, which are basically alpha 1. Okay, so you have this alpha 2 in the brain. What is the nature of this alpha 2 receptors. Whenever you stimulate them, these alpha 2 receptors in the brain, they will block the release of sympathetic outflow. They will block the release of sympathetic outflow, and that decreases the BP, blood pressure. So all centrally acting antihypertensive agents like clonidine, how are they acting? They cause stimulation of alpha 2 and block the release of sympathetic outflow and decrease the blood pressure. Okay? Here there are three confusing concepts, completely against our normal logic of human mind and living. What are they? First, it is presynaptic called alpha 2, unfortunate. Then the drug which stimulates it, we expect it to increase, but no, stimulation inhibits. So if you remember these two paradoxes, you will remember how alpha 2 agonistic agents centrally acting can act like a antihypertensive. Summarize, where is beta 1? Heart. Stimulation lead to increased heart rate. Beta 2, smooth muscle. Stimulation lead to bronchodilation, uterine relaxation. They are also used as tocolytic agents in the obstetrical practice, albuterol and all. Then alpha 1 is on vessel. Stimulation lead to vasoconstriction. Hence we use alpha 1 agonistic agents to raise the BP whenever the person's BP falls. And alpha 2 is located in the brain, and it is typically pre-synaptic, and stimulation of that will lead to sympatholysis, and that lead to decrease in BP. So this is the basic yarn of autonomic nervous system physiology. You should be 100% sure about. So before prazosin, after prazosin, you have given drug 1, drug 2, drug 3, drug 4. Now, what are these various drugs fundamentally? Drug 1, norepinephrine, tyramine, isoproterenol and epinephrine. Drug 1 to 4. So basically, if you take norepinephrine versus epinephrine versus isoproterenol, they are all catecholamines, but they differ in their affinity for alpha 1, alpha 2, beta 1, beta 2. So accordingly you must know what is the affinity of each of these catecholamines on different receptors. So accordingly only those drugs which have a high affinity for alpha 1 receptors only will be affected by giving prazosin. All those drugs which are alpha 1 agonistic will be affected by giving prazosin, which is an alpha 1 antagonistic drug. Any other catecholamine whose catecholaminic effects are not because of alpha 1 agonism, that is not affected by giving prazosin. Accordingly you must check that. Now patient is having neutropenia, refractory leukemia, and you have done imaging, and what is this sign called? Crescent sign. And immunocompromised people are vulnerable to which important infection, doctor? Invasive aspergillosis. And how do you manage invasive aspergillosis? Fundamentally, you will be giving antifungal agent, and it will be binding to the ergosterol, the antifungal agent, and that is amphotericin B. Mechanism is by binding with ergosterol is what need to be remembered. Now you have been shown a Bahubali sword. So in which war is this sword used? So anesthetists use finest needles on the planet Earth, to anesthetize our life. So what is this needle called? Tauhi needle. Tauhi needle. It is basically for giving epidural anesthesia. We use the Tauhi needle. We can pass a catheter through this needle, and we can keep the catheter inside, and accordingly give boluses of anesthetic agent. Some of you are going to be top line, top notch anesthetists. Next year by this time you will be seriously doing duties, anesthetizing hundreds of people. So Tauhi needle, don't forget. What are the modern buzzword, doctor? Nobody wants a pain in life. Even labor should be you want to be smiling at the time of labor. You don't want to really cry at the time of labor. When the labor pains only are made painless, PG preparation pains must be made completely anesthetized. That is the reason we are conducting the mock test. So, Tauhi needle is that epidural administration of high yield facts. Right? So, high yield topics. So, is it used or not used? It is very much indicated for epidural anesthesia is what you have to basically remember. Now, what is this technique of anesthesia called as? It is intravenous anesthesia. Bayer's block it is called as. So, you can give lignocaine, but you should never give bupivacaine. Bupivacaine has a significant cardiotoxicity. So, you don't use bupivacaine in the management of intravenous regional anesthesia called Bayer's block. Then you are being shown an anesthetic technique. What is this called? It is called interscalene approach for the brachial plexus block. It is called as. So in this approach, ulnar nerve is basically spared. Ulnar nerve also comes from brachial plexus. Which cord it will come from? M4U, medial cord. LML is lateral cord. Then rats, radial, axillary, thoracodorsal. Come on, doctor. Because of you, I am able to remember. Otherwise, 25 years back, anatomy we studied. So, just because of you, I am able to remember. So, ulnar. Right. Then, but what are the complications of this? See, here you are injecting interscalene approach by very close, that needle is passing to the apex of the lung. So there is a high risk of inducing a pneumothorax, phrenic nerve palsy, subclavian artery puncture, etc. are the complications. Bloody diarrhea patient is having. And what is this typically? जिस दिल को प्यार करेगा वो गाना गाएगा. You remember that old movie? Heroes used to hold that accordion. Vaijayant Mala Bali days, Raj Kapoor and all. Nowadays heroes are not holding accordion. They are directly holding the heroine. So the accordion, those days there was no permission. So they have to hold this and that and think that they are holding the heroine. So accordion. This one, this instrument. Like that, don't you see the folds in the barium? It is typical feature of pseudomembranous colitis. You will come across accordion sign, it is called as, is what need to be remembered. Then, there is a large bubble wall which is being shown to you. Are you feeling the thumb printing? Yes, thumb printing. Whenever there is a edema of the bowel wall, it can be due to ischemia, it can be due to inflammatory bowel disease. There are many causes for that. So, ischemic bowel, Crohn's disease, pseudomembranous colitis, anything can lead to the development of thumb printing, not only ischemic colitis. We all remember characteristically that it is ischemic colitis. There are another 10 causes which can lead to thumb printing sign positivity, is what you need to appreciate. Now the sigmoid colon in the barium is being shown to you. What is this appearance? Is it reminding you the sawtooth appearance? And it is because of the presence of multiple diverticulae. The sawtooth appearance is what you need to remember. In radiology, there are totally 300 films, characteristic features, which you have to go through at least that film once. Because examiner's favorite question, image based questions, is to put classical radiological films like tram track calcification in Stooge-Weber, etc., etc. So, in our on every Friday we have a radiology class. Immediately class is over, we will put the video into online. Totally 26 hours of radiology review had been done. That will help you to remember most of the common questions and radiographs shown in the entrance exam. Now doctor, a supine abdominal film has been taken. What are you seeing in this? There is a gas in the colon, but suddenly there is an abrupt stopping of the gas. What it is called? Colon cutoff sign. Typically colon cutoff sign. If I don't show you radiograph but I ask you, where do you see colon cutoff sign? Reflexly you will answer pancreatitis. But if you show the radiological picture, first you must imagine a gas in the colon here and it is cutting off over there. And then at least you, in this kind of questions, look at the options. Possibly what examiner is trying to look for. So, ischemic colitis, is there any thumb printing? No. So, a colovesical fistula, is there any bladder or anything shown? No. Then why will he give? So, possibly between the two. So, colon cutoff sign, acute pancreatitis is what you need to remember. Then doctor, this is the same patient who had colon cutoff sign there, and when you have done CT, what is this? This all edematous organ is? Are you able to see? This is horizontally extending. What is there here? Pancreas. CT scan revolutionized the management of pancreatitis. There is a, what is that scoring system called? Balthazar? Not Ranson's. Ranson's last civilization की बात कर रहे हैं आप. What is it? Radiological CT severity scoring. Balthazar? Something like that. Come on doctor. CT prognostication system, Apache system, Ranson's criteria, all these things. See, when you do CT, you will look for how much pancreatitis is there. 1/3 or more than 2/3 or between 1/3 to 2/3. One criteria. Second, peripancreatically are there any collection of fluid you will look for. Is there any pseudocyst is there you will look for. Based on all these radiological features, you will grade the severity of CT, of pancreatitis on CT. Okay. So, you must go through all that. Then, that is all about the image based questions. Okay, doctor.